Myself, Dr. Uma, Professor of Pathology. I will be taking today on the class on WBC disorders, in which I will mainly concentrate on non-neoplastic conditions. Because once you know this about non-neoplastic, then we will go for neoplastic conditions. So, in today's class, what is that I'm going to cover in the objective of this class, that is the session is, first we will know about the normal granulopoiesis. So what is this normal granulopoiesis? Where does it occur and how does it appear? Then we will go with how to identify the various WBCs in peripheral smear. That is why morphological identification. At the last, we will go with where are the conditions where you see leukocytosis. The two we will split up and tell where all you see leukocytosis and in which all conditions you see leukopenias, which means increased and decreased WBC counts. Then we'll discuss about how this leukocytosis differentiate between leukemia reaction. So is that clear? So, leukocytosis differs from leukemia reaction in which way? You can jot down the doubts and you can ask me the last, or you can also ask me. So first, before. So production of WBCs is called as granulopoiesis. So this production takes place in bone marrow, right? So the bone marrow is the main site for production, and we know that how the normal hematopoiesis mainly takes place. So all this starts from pluripotent stem cell, hematopoietic stem cells. Like that only here they develop from myeloid progenitor cells, which has a tendency to give not only WBCs, but also they produce erythroid as well as platelet series, that is megakaryocytes. Whereas you know that lymphoid series is altogether a progenitor cell. As this progenitor, that is hematopoietic stem cells mature, they give right from the blast to the peripheral WBCs. One more thing we have to know that this granulocytes, when they are produced, the duration for their maturation time is almost about 10 to 12 days. And in the marrow, there is what we call it as production-wise, when we compare to what extent myeloid is produced and to what extent erythroid will produce, is called as myeloid to erythroid ratio. This is how we represent. And this is how we mention it. ME ratio in a short form. What is its normal WBC to normal RBC count is 3:1. So now you already now got an idea that though in peripheral smear, WBCs are very, very low compared to the RBC count, which runs in millions. Here, this happens because the lifespan of WBCs is very slow. That is the reason, because to regenerate the pool, circulating pool, the rapid rate myeloid is produced, because even the lifespan is very less. It's very days, right? 8 to 10 days. Sometimes it may go up to 12 days. So that's the reason the rate at which WBCs are produced is too high. The storage capacity wherein the barrel is 10 to 15 times. It has this capacity, which means whenever there is acute stress or certain conditions which there is defective production, immediately it will not show. But because it is released from the storage pool. Okay. So I would like you to be knowing this view how their maturation takes place. When it comes to myeloid series, know that in the bone marrow, it starts from myeloid maturation, it starts from myeloblast, then it's to site, and then myelocyte, and then it goes to metamyelocyte. Then comes the band form and neutrophil. So this is how it develops. Here you can observe that as the cells mature in the peripheral smear, the nuclear loads, can you see here? It is somewhere around here very clearly. As it matures, you can see it gets located. The lobation starts as early as metamyelocyte. To some extent, this indentation may not be seen in myelocyte. Right? Clearly, you can identify metamyelocyte. You can see that the nucleus also starts developing granules. Promyelocyte has numerous granules. If you see identified in bone marrow, that is how we identify. It has numerous granules. And also remember, nucleolus disappears as it comes to the periphery, which as it matures to the middle. Neutrophil, nucleolus, or nucleolus will be identified. So it disappears. So, nuclear indentations are when we come to the neutrophil, you see that there are elevated three to 5 loops. So this is the pictorial representation. Here you can see the morphological representation very clearly. So you can see here 1, 2, 3, 4, 5. This is 5 loops. This is erythroid series. We will not discuss that. We will not discuss in this class. Okay. So hope you got it. And one more thing, the peripheral smear doesn't contain these precursors. So if you see these precursors, then we have to see what it is, which I will later discuss. So precursors, that is blast, promyelocyte, see in the peripheral smear. And that we can see is, we can see occasionally band forms and always neutrophil. That is how we identify that it is myeloid maturation, right? Neutrophils. If there are certain conditions, we use this term. We call it as shift to left and shift to right. So shift to left means the immature ones are seen, like maybe myelocyte, metamyelocyte, even numerous band forms. Whereas shift to right means neutrophils are increased. Okay. When that will happen, we can discuss it later. Similarly, here also, monocyte not be so many precursor wise, it also develops from blast, monocyte or monocyte. So that is how it happens. So in peripheral smear, what do we see? Do we see monoblast or monocyte? See, site, right? Then in lymphoid series also, the maturation starts from lymphoblast, from lymphocyte, and then the mature form is called as lymphocyte. Again, here also peripheral smear shows lymphocytes only. So that would like you to make it clear. So now coming to how to identify what, how many number of cells, all these things we will discuss. So now we will come to peripheral smear, peripheral blood picture. So the WBC count range, like any other hematology always we give ranges. Like hemoglobin is given in range, RBC count is given in range. Like that only, WBC count is also given in range. What is the count? It ranges from 4,000 to 11,000. Some people even tell it. So 500. Doesn't it? That is how it is. And this count is per micrometer. And when you do the differential lymphocyte count, that is when you see how each one is distributed, you see according to the predominance. So neutrophil is the first WBC, which is the normally you see predominantly. What is its count? When we count for 100, this is the range. It can be as low up to 40, it can be as high up to 75 to 80. Just take one. And the lymphocyte count, again, when it is counted in 100, it can range from 20 to 40%. We see what is called as absolute count, that is per microliter. Okay, when we say per microliter, so for 4,000 to 11,000, what number of cells we see in microliter? That is up to 2,000 to 7,500. Same the calculation. Okay, so lymphocyte, we keep it to make it simplify to your level as undergraduates. We'll just keep it for 100. Okay. So then comes this all we call it as absolute counts. And then comes the monocyte. Range again. Everywhere, remember in hematology, we use ranges, no fixed values. Monocyte again is 2 to 10%. Okay. Some people tell it as 8. Still, you can consider. Eosinophil 1 to 4%, even 5, 6 can also still be considered normal. Basophil is 0 to 1%. So hardly we tend to see. So when you make a differential count, you please remember most of the time for people we give a normal smear, and hence you will see very less basophil count. Until and unless really there is some pathology in it, you tend to hardly see basophil. But most of the time in a normal reference smear, you tend to identify neutrophils and lymphocytes. And occasionally you definitely see your lymphocyte also. We'll see about the morphology and in which conditions now you can identify increase or decrease or decrease. Now there are here 5 WBCs, right? So the 5 WBCs here are, the first one is, you can see here it is. What do you think you can identify? What is the lobes? Just look at it to compare it with the other cell. See here it is about horseshoe shape. Okay. And here it is 2 lobes. And again concentrate here on granules. Here you can see again lobated cell clearly. And then there are granules. So your doubt runs with these things. What do I call this? Here also something granules are there. Here also granules are there. Yes, this part to simplify very easily. Peripheral smear, we tend to call WBCs identified based on categories. One is there granulocytes or there agranulocytes? So, what is this? How do you identify whether they are granulocytes or agranulocytes? Very simple. Can you see here? Fine granules, some can be big, coarse. So, this is first identifies this granulocyte or agranulocyte. So, this is granulocyte. Again, here is clearly granulocyte. Here, what granulocyte? Again, here, very big, large granules, right? This is also granulocyte. Now comes to morphology. Here it is horseshoe shaped. So this is a band form. You sometimes even can get confused to neutrophil or things. Okay, as an UG undergraduate. But to be very specific, it is a specific, it is a band form. Next, this is lobation. Lobation you can see, yes. Here also lobation is there, but here it appears like a spectacle. Always remember, bilobed, 2 lobes with the granules, coarse granules, the 2, and compare here with the granules of this. And the granules here are purplish, and they are fine, little purplish or lilac color. And this is called as, this cell is a neutrophil, whereas this cell is a basophil. So most of you as undergraduates will confuse here. So please remember, you have identified as a granulocyte, and now your confusion is it a neutrophil? Is it a eosinophil? So then go to your granules. Pinkish, somewhat orangish granules, little big is your eosinophil. You see very less count. And purplish and fine granules, smaller granules is your neutrophils. Then here comes your, then we will finish up this granulocyte also. Here you very rarely tend to see, this is a characteristically how basophil appears. Don't think so. Many of you will see in your peripheral smears so easily. So please remember this picture in the mind. This is having a somewhat dark blue granules, and it almost covers the nucleus. I cannot tell that how many loops are there. How is the nucleus at all? So to that extent it covers, and it almost resembles the size of an eosinophil only. So it is coarse, big, large granules. So that is how basophils look. Now comes to the small cell, right? The smallest of all the WBCs you remember, and that is your site. And remember, the nucleus is always round and very scant compared to other scant cytoplasm. So this is a site. And then what is called as a WBC with, what can you see here? Is it clearly round? No, right? It is showing some kind of kidney shape. Otherwise, we call it as bean shape. or some people can also comment it as indentation. See, right? It is more indentation. Sometimes it is more indentation. See, and this is how you identify a site. And also, there is one more. It is the largest of all the WBCs. Okay, so microns is somewhat 12 to 14 microns. So this is how site is identified. I will go to the same thing I have represented it. Okay, so please make clear this is how you identify the WBCs. Now, where all the conditions where I say increased and decreased, right? That we will see. So the conditions where we see increased WBCs, that is here mainly neutrophils, is we call it as neutrophilia. So normally I told you whenever there is 11 to 5, we call it as normal. Imagine it has crossed maybe 15,000, 18,000, all these are terms go. Right? Now we are specifying each one, all the WBCs as we have categorized it. So let's see that. So now, where do we see neutrophils more? See, this is how you identify. Can you see here? Too many neutrophils, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. See, now you can see almost 10 neutrophils. And remember, this is a 40x. So how do I count? How do I tell this is more? So you identify, you make almost 10 fields, you try to count, and this is how we tell. And then we take an average. And in 40x, imagine you have got maybe 8 or 10. Now I got 8 to 10. So we'll keep it 10, right? And then that you need to multiply. If you see in 40x, you need to multiply in 2000. So 10 into 2000, somewhere it falls into 20,000, which means definitely the neutrophil count is increased. That is how we calculate. Okay, so here always see, always remember the dictum until unless for an undergraduate level, bacterial infection. Whenever they ask, whether in Viva or in maybe a short mark question like that, it is always bacterial infections, you see neutrophilia. Okay. Then in other conditions, burns, wherever there is stress, operations, in all these conditions, there is also neutrophilia. Leukemia, of course, which I tend to avoid here. I've put it in last. All the malignant conditions, wherever there is maybe neutrophilic leukemia, all this also it is. My dictum I want you to remember is bacterial infections and stresses. Next is penia. So I'll cover here only. Penia is reduced. So which means reduced less than maybe 20 for 100. So maybe there. These conditions you see for absolute count, it is very less. So maybe it is in 500s. So that you see in cases of typhoid, paratyphoid, and certain drugs and chemicals. Then we'll go to what is called as certain morphological variation. Do I want to remember this? Yes, we need to see that because if kind of we tend to see such morphological variation in the WBCs, especially toxic granules, which I'll be discussing. And there are what is called as dot bodies and pelvic anomalies. Those two I would like to stress at this point. So first, what is this pelvic anomaly here? Can you identify? This also looks very much pilot, right? And maybe you can certainly get confused with what cell? Yes, eosinophil. Okay, so but if you compare here with the granules are large or small, purplish, fine. So they are neutrophils, and these neutrophils you see in what is called as in benign congenital condition sometimes, and that anomaly is called as Pelger-Hute anomaly, and that is in autosomal disorders. They have seen that it is congenital congenital condition, which is a autosomal inherited, dominantly inherited. And these granulocytes are pilot, and some of them even called it as Prinzner's cells. Or you can also see sometimes pseudo means which is not because of anomaly, but they appear vibrant. So where all we see in certain myelodysplastic disorders. They've also seen certain drugs can also cause them. So just morphology remember and remember pale cells and they are a genetic condition. They are seen in pseudo in cases of myelodysplastic conditions. And CMS. And this is again a neutrophil morphology. Instead of you know that it can be 3 to 5, which is normal. But here the WBCs are having almost here 1, 2, 3, 4, 5, 6. So they're having almost 6 segmentations, right? So these are called as hypersegmented. So then more than 5, they are called as hypersegmented. And it is seen in where, since RBCs are covered in the disorders, it's mainly seen in WBC, in cases of which type of anemia? Mainly in megaloblastic anemia. Maturation is defective, right? Everything related to DF maturation. Next, what we call it as bar body or drumstick body. First, I'll show you the morphology. See here, neutrophil, you are identifying the segment. Here, lobes here. This also looks almost like this lobe. Very small, right? So this is like somewhat tag like. You call it as somewhat like a tag is attached, right? Like a polyp. And this has some, and this is actually what we call it as bar body or a drumstick shaped appendage. These we see in cases of females. And this is very easy to identify in a peripheral smear. Imagine you do not the sex, the patient who was given the sample, and you see such neutrophils having a bar body, then you can easily tell this is a sample of a female. And it is indicates what? It mainly indicates inactive X chromosome. And sometimes you also see males with Klinefelters. Why Klinefelters? Because there is double X, right? So it is double XY. So here the another X can be manifesting as a bar body. Means what is known as toxic granulation. All these are non-neoplastic, right? So this, I will first show you the picture. So toxic granulation, what are this? See here, the neutrophils are showing somewhat bigger granules, right? And numerous. This is flinching, right? You can see something is abnormal. Initially, you'll think, is it eosinophils? Is it some kind of darkish stain? No. So what is so toxic about it? The thing is, we call it because I think inflammations, when the inflammations is high, imagine severe bacterial infection, bacterial septicemia. In these cases, the WBC shows this cytoplasmic granules which are having this force. Why? Because they are impaired. Because fast the bone marrow starts producing the granules too much WBCs and these granules try to ingest. So that's why we identify. Okay. So large number of granulocytes are produced in inflammatory conditions. Okay. And these are nothing but eosinophilic granules also seen in all the maturing cells of WBCs. Next, we see lymphocytosis. So we saw about neutrophils, now we will see about lymphocytosis. Where do we see this? Lymphocytosis, remember again, like neutrophils only, neutrophilia. Lymphocytosis is seen in viral infections. So the dictum easily viral infections, lymphocytosis. Okay. There are certain other conditions also I would like to remember. Infectious mononucleosis, tuberculosis also can cause. Leukemias will keep it later. Okay, so leukemias, all the WBCs, there are certain leukemias where lymphocytes are increased. They will not confuse at this point. Penias, again, stress causes, okay. Then marrow failures. This we can always remember. Whenever there is marrow failure, there is immunosuppression. In these cases, penias are there. Irradiations can happen. So remember that penias in the bone marrow suppressive cases. You see here, all you can see, what are you able to identify? Look at the lobes, look at the cytoplasm. Is there any damage? So with all that morphology I told you, clearly you can tell these are lymphocytes. And the moment you see here, only that cell is seen. So definitely it is lymphocytosis. Even if you make a count and count it, imagine if this is in 40x, try to count them. Almost they are more than 10 to 12. So again 12 into 2000. Almost it will be 24,000. So imagine 24,000 count. So that is also increased. Lymphocytosis is there. And absolute lymphocyte count is also there. Okay. Now we will come to eosinophilia. Okay. I told you identify eosinophils by bilobes and characteristic is granules. The granules are what? The granules are orangish, pinkish, right? And they are bigger, coarse. And they are what is called as spectacle shape in place, no? Bilobe. You see some as though there are two lobes in between a thin connecting chromatin strand. And this, if you count only smear is having eosinophil, full of eosinophils. Okay. So we need to know that absolute eosinophil count is, that is, when there is increased, generally dermatologists or pulmonologists, if there is asthmatic features or skin allergy, they tend to ask eosinophil count. What is the EEC count, which means absolute eosinophil count. So normal is somewhere 40 to 440 per microliter. In that case, they specifically tell us what is the EEC or what is the eosinophil count. They are very keen. Okay. See here, that's what. The causes of eosinophilia is all that allergic conditions like asthma, seasonal rhinitis, eczema, skin infections, dermatosis, all those things. So remember, other thing is parasitic infections. Like all parasitic infections can also increase. And certain Loeffler syndrome, this is in systemic pathology we learn it is nothing but pulmonary infiltration with eosinophilia. Certain drugs you can almost, in all these philias and penias, drugs also is a contributory condition. And remember neoplastic, they may ask you in Viva, name some neoplastic condition, they will see eosinophil count, very weighted. So sometimes these two, CML and Hodgkin's lymphomas. And eosinophil somehow is seen that it is related with adrenal function. So whenever there is adrenal hyper functioning, then also they have seen that there is increase in eosinophil. So hyperadrenalism of Cushing's, all this also causes eosinophilia. So penias, so steroid-related conditions can also cause penias. So now the last one is monocyte, right? So you saw that as kidney shaped and biggest of the WBCs. So monocytosis can be seen in tuberculosis, acute bacterial infections, certain protozoal infections, and monocytic leukemias. Leukemias we give it, and sometimes immunological, that is, connective tissue disorders, immunological disorders, all these things, autoimmune diseases, it will be increased. Now, basophilia. So we know that basophils normally we tend to not see at all, 0 or occasionally 1. So basophils are told by large purplish granules. So where do we see? We can ask in Viva. So remember the conditions. Philias we will remember. Basophilia in CML, chronic myeloid leukemia, polycythemia vera, sometimes in mixed edema, Hodgkin's disease as well. Okay, so again, just to recap the basophil morphology. This is what is called as, sometimes people call it as atypical lymphocyte or transformed lymphocyte. Don't have to confuse as you go and see, is it leukemia? No, that we will compare there also. They are activated. You can see cytoplasmic being activating. It is directing towards the bacterial infection, cytoplasmic pores. So it is atypical lymphocytes, which look as though it is mimicking. So viral infection, sometimes even in kids also, we see this. Next, the last I would like to cover in this topic is infections. So what is leukemia reaction? So the name itself indicates moid. Leukemoid means, is it leukemia? No, it resembles. So it is a bridge you can think. There is leukocytosis. Now there is leukemia. What is this leukemia? So it resembles leukemia in a non-leukemic person. So that's how it is. Then how do I differentiate it? There are certain things which I help you how to differentiate. They will not have clinical features like leukemia, wherein they may be having leukemia people. Generally, we see to tend to see organomechanics, which means maybe spleen, hepatomegaly, all those things will not be there. Lymphadenopathies may not be there. Okay, so this is how we tend to differentiate. But certainly, it is more than leukocytosis. What is this? The counts may be as more than 50,000, sometimes up to even 1 lakh. So that's how they've classified it, whether it is myeloid, this means, which means, is it more of WBCs of neutrophils, myeloid leukemia reactions, and lymphoid, which means more of lymphocytes are seen lymphoid leukemia reaction. So remember, this also is seen in infections only, but more extensive infections. Okay. But how do we differentiate? Yes, in peripherals, remember, you don't see blasts, but you see some amount of immature cells like myelocyte, metamyelocytes. If at all you see blasts, it will be less than 3 to 5%. Okay, that's how. So, no organomegalias will be there. Blasts will be very less, maybe occasional or not at all. But some shift, I told you, whether it is shift to right or left. Here, the shift is towards the, that's how. Okay. That is towards the immature cells. Next comes the lab findings. Yeah. Is it enough only morphologically? Yes, you can stuff fix if you're enough. But morphologically, and there is an additional supporting is NAB score, which means they use what is called as neutrophil alkaline phosphatase. Or some people also use as leukocyte alkaline phosphatase score, which is nothing but they try to stain it and then they see the granules. And that is NAB score is high in non-neoplastic conditions, which means in leukemia reactions, the WBCs are still normal. They are filled with toxic granulations. Of course, right? So I told you in the beginning, infections leads to toxic granulations, and these granules are more in the leukemia reactions, right? And they're mature. So when you do the staining with this leukocyte alkaline phosphatase, these enzymes are taken up more with this toxic granulation, and they score it, the granules, based upon how much they count it. And that score they give it, and that is seen more in leukemia reactions, whereas very low, lower than in CML. Is this enough? Certain still, some people don't follow the scoring. They still have a doubt, they go for definitely even patient may be concerned. In that case, as we confirm it with cytogenetic studies also, wherein chromosomal abnormalities are not identified. I will not go what anomalies, but we will still see in CML, but still remember, negative Philadelphia chromosome is what we ask you to remember in your undergraduate. So that is what I told you. High lab score is seen in leukemia reaction because there is shift to left. And yeah, did I confuse it? Yeah, shift to left is maturationism, right? So lab score is low lab score is seen in CM. Please remember, shift to left is more mature series, shift to right is immature series. So normal count, normal lab score, there is at a normal lab score, CML it is very low, leukemia reaction it is definitely very, very high. Okay. So that's how we remember the leukemia and leukemia reaction. Then is next one, what is called as lymphoid leukemia reaction. Where do we see this? This is seen in cases of again certain infections. Okay. So here it stimulates here CLL total count is less than 1 lakh. It stimulates like not stimulates, it simulates like a chronic lymphoid leukemia. The same picture I have, which I have put it here for leukocytosis only. You get confused. Is it leukocytosis? No, still it is lymphoid action. Okay. Hope you understood my class. Thank you so much for your patient listening. Thank you.